Yeah, TGA is a kind of a complex analysis. There is a large spectrum of TGAs with VSDs, without VSDs. Try to go through the simple forms of TGAs. There is two forms of TGAs, right? There is the DTGA and LTGA. And there are two different separate entities. Management-wise, anatomy-wise, hemodynamic-wise, there are two different entities. And the diagnosis is very simple. To be answered from the axial view, from one cup, could easily say that this is a D loop of the heart during the development, or it's an L loop of the heart, where is it a DTGA or an LTGA. So in a normal subject, on the axial cut, where you see the pulmonary to the aorta, so the pulmonary is always anterior to the left, and the aorta usually is posterior and on middle line or on the right side of the pulmonary, right? As soon as you see that the aorta is anterior, then it's a TGA. If it's on the left side, then it's LEVO, which is LTGA. If it's on the right side of the pulmonary, then it's a DTGA. Okay. So this is a simple form to diagnose it. And this is pre-repair. Right? After repair, sometimes the anatomy change. But diagnosis-wise, if you are working in a pediatric hospital where you are seeing a cross-sectional imaging, then aorta anterior is a TGA. Right? And then you will see whether it's an LTGA or a DTGA, depends on the aorta is on the left side of the pulmonary or on the right side of the pulmonary. Because this will tell you the exact position of the ventricles underneath, whether they are on the left side or they are on the right side. Because in an LTGA, you will see that the right ventricle is on the left side, right? But on a DTGA, is the normal arrangement of the right ventricle and the left ventricle, right? Okay. So when you see the aorta anterior, it's a DTGA. It's a TGA, right? And then if it's on the left side, then it's LTGA. And then when you go down to the ventricles, you would expect that the right ventricle will be on the left side. Yeah. And in order to diagnose any congenital anomalies, there is a systemic way to do it. There are systemic steps. So there are two classifications, Van Bra and there is this Anderson. Both of them are similar. So they usually, when you read an echo of congenital, they will go through the situs. That's the first step. Whether the situs is solitus, so the stomach is on the left side or on the right side, and so on. And then they will describe the apex, whether you have a dextrocardia, or it's a levocardia, or this mesocardia, so where it. And the second line is going to be the concordance. What exactly is the concordance? Is the relation between the atrium to the ventricle, which they call it atrioventricular, and then the ventricle to the great vessels, which is the ventricular arterial. So we have AV and VA, right? Yeah. In a DTGA is one thing, and in the LTGA is something else. So in a DTGA, back to this picture, if you see, so the right atrium goes to the right ventricle, but then the right ventricle will go to the aorta. So where exactly is the discordance? In the VA, right? But in an LTGA, the right atrium goes to the left ventricle, and then the left ventricle will go to the pulmonary artery. Both of them. Exactly. So there is an AV and VA discordance. Yeah. Right?
So it would be better, right? Function.
The LTG is the one that.
LTGA.
Very good. Okay, then let's move to the next slide.
It's still behaving.
Yeah. That takes us from the anatomy to the hemodynamic point, which is very good. That's a very good question because it made it easy to describe this slide. So a normal circulation, we have the superior vena cava, inferior vena cava goes to the right atrium, right ventricle, pulmonary artery, to the lungs, take some oxygen, go back again, pulmonary veins, left atrium, left ventricle, and then to the aorta, right?
Yeah.
So for the next two cases where we described AV and VA, let's say that's day one for this patient. Who would live and survive, and who is not compatible with life? Which one of those?
L would be compatible with life.
Yes. So L is going to be compared. This answers your question.
Yeah, because they're the wrong chambers connected to the right.
But the circulation is fine.
Yeah.
It's fine.
That's why most of those patients are being, or sometimes being discovered at the age of 30 or 40. They are not getting blue, they are fine. And at this age, 30, 40, when they start, the right ventricle starts failing because it's the systemic ventricle. And we said that the right ventricle is not the ventricle that's being created to hold high pressures, right? And being the systemic ventricle, the right ventricle has been for 30 or 40 years facing 120/80, which is the normal pressure if the patient is not hypertensive.
Yeah.
Right. So the right ventricle starts to fail. The patient starts getting palpitations, arrhythmias, syncope or fainting and so on. And then doing